Hi, I'm really happy to be here today. I'm Kirsten Carroll, and I'm the CEO of Can Do Health. For today's agenda, we're going to talk about principal illness navigation in stroke. We'll start by introducing the concept of what principal illness navigation is meant to accomplish. And then we're going to talk a little bit about why it's relevant in stroke specifically and how we think of the problems of post-acute care in stroke. I'd like to review some data from a paper that Can Do recently published. It's our first peer-reviewed journal paper looking at the feasibility of delivering telemedicine-based principal illness navigation in post-stroke populations. And then I'm going to transition to Karen Seagraves, who I'm joined by today. And Karen is going to talk about how this translates into outcomes that matter to service lines and hospitals. After hospital discharge, stroke patients frequently become lost within what is a very fragmented healthcare system. And so we're so excited that starting in 2024, principal illness navigation services are now approved by CMS for coverage to help patients manage the complexities and the gaps in the healthcare system when they return back to community outpatient settings after stroke. When we talk about complexities, there are layers of these for stroke populations. So patients are managing multiple underlying conditions that put them at risk for stroke. They're managing new sequelae of the stroke, things like memory deficits, movement deficits, cognitive deficits. And then they're also trying to work in a really complicated healthcare system where their own benefits, insurance, and employment status might be changing. So with principal illness navigation, we primarily care for the stroke patient, but we can also include their care partners and work with them on navigating this return to home. The services are covered under Medicare Part B as outpatient services. And through principal illness navigation, we provide guidance, navigation, and we support patients through their recovery. When CMS wrote the rule to cover these services, they defined 8 core elements that they expect a patient to receive under principal illness navigation. So if we look at this graphic, at the top are the services we're delivering to the patient. You can see we start with a holistic patient-centered assessment to understand all these elements of their disease and living situation. We help them find supportive services, and we help coordinate their care post-discharge. We also provide health education. One of the interesting things about principal illness navigation is that our goal is not to manage these patients forever. We're not taking over as their primary care provider. We're not taking attribution for these patients. Our goal is to actually help them get on a better trajectory for recovery and to actually have them then be able to manage their own recovery better. So you can see in the bottom row of this graphic, things like helping patients build their self-advocacy skills, particularly if they're dealing with something like aphasia, where it may be more difficult to communicate now. Helping them learn how to navigate systems. Often these patients are not expert in utilizing or navigating the healthcare system. Helping facilitate some of the behavioral changes that might help them adapt to their stroke or address the things that put them at risk of stroke. And then helping them build support networks, mentorship, and inspiration for managing their disease. So principal illness navigation was pioneered in cancer care. It's newer to stroke. And one of the goals of Can Do Health is to be the industry leader, delivering the first set of principal illness navigation services that were really designed specifically for stroke populations to address their unique needs. So next, I want to talk a little bit about why PIN is so relevant in stroke care and the landscape of post-acute care recovery and stroke. We hear a lot when we talk about stroke about the urgency of stroke. You hear statistics on how many people are having a stroke every 40 seconds. You hear statistics of how many brain cells die every minute. There's a slightly different set of statistics that we look at for stroke at Can Do, and they relate more to the lived experience after the stroke has happened. So the first one, and this is the one that our mission is really centered around, is this devastating statistic. And this came out of the AVERT trial, where they looked at outcomes and access to care for young stroke survivors around the world. And they found that a year after stroke, 28% of survivors rated their quality of life as poor or worse than death. Now, the average life expectancy after stroke discharge is 10 years. So that's a very long time to live with very low quality of life. There needs to be an economic logic as well when delivering this within the US healthcare system. And remarkably, what a lot of people don't realize is how expensive stroke is as a diagnostic history once people have had one. Stroke survivors are actually the most expensive cohort of patients in Medicare. On average, they need over $35,000 a year of services, and just the first year of post-acute care and stroke aggregates to a $25 billion healthcare expense that we're already spending today after they've left the hospital. Why is that so high? It's because readmissions are incredibly high in stroke populations. Readmissions to inpatient settings account for over half of the expense of post-acute care and stroke. So at 90 days, we see over 26% of patients have been readmitted as an inpatient back into hospital. And by 1 year, it's about half of patients. And importantly, most of them have been readmitted more than once. Why are they so vulnerable to readmission? There are underlying conditions, but you also have the reality that nearly half of this population now have dependent disability 90 days after discharge. So just those fundamental things of activities of daily living. Can you bathe? Can you toilet? Can you buy your groceries? Can you do your basic household tasks? All of those have been compromised, and they end up creating a domino effect of readmissions far beyond just stroke recurrence. So in the next slide, we're going to look at what are those timings and causes of readmissions over time in a stroke population. So what we look at in this slide from the left to the right is the 365 days after stroke. And we look at a variety of causes of stroke readmission. We have two of them highlighted. The darker purple is patients who are readmitted for a recurrent stroke or a TIA. And interestingly, you can see that in the first 7 days, that is the dominant cause of readmission. But at 30 days, it's really started to plateau, and you don't see a lot of this after 30 days. The lighter purple is readmissions due to infections and sepsis. And this was a real aha for us. We pulled this data out of a database we built. It's 100% of claims data for Medicare fee-for-service patients who had a stroke in 2018. And we cross-linked the data and followed these patients for a full year after stroke. And you see that infections and sepsis are a huge problem that only continues to grow. And patients are not getting nearly the same level of education and awareness on how to prevent this and recognize this as they are around recurrent stroke. So if you think about this domino effect of sequelae of stroke that lead to challenges with the activity of daily living, that lead to infections and sepsis, when patients don't know how to sit or how to lie down properly, they can develop pressure ulcers. They don't know how to do a daily skin check. They don't recognize it. And by the time it's found, it might be infected. So if we look at patients who might have a numb cheek pocket, these patients may not know how to do a mouth sweep after they eat, and so they may aspirate food particles from that. And we work with so many patients who actually aren't comfortable bathing and toileting anymore. And so their personal hygiene declines, they develop UTIs, and these UTIs very often present with altered mental status. The patients don't realize it's a UTI, they think it's just post-stroke fatigue, and by the time they realize something's really wrong, they're septic and back in the hospital. So we had a hypothesis, all of these are things that can influence by providing better education, better support, better care coordination for these patients. So the next thing we'll look at then is this just a problem in the most severe strokes, or do we see this in broad populations? And I think unequivocally, when we look at the data broken out by NIH stroke score, what you see in this chart is on the far left is the least severe strokes and the far right is the most severe strokes. And the bar charts are the percent of patients who have any readmission. And even in NIH stroke score of 0 to 5, which are the more mild strokes, you have 23.5% readmission at 90 days. So we tend to focus most of our resources, planning, and attention on the most severe strokes where it's more obvious that there are going to be problems. But these minor strokes still have lots of readmissions and need more care than they're receiving today. So if we transition from why is PIN important to is it feasible in stroke patients, I'll just take a few minutes and review the data that we just published in Stroke Clinician, which is the new peer-reviewed journal that's issued on a quarterly basis by the ANVC. In this paper, we wanted to look at whether or not it was feasible to deliver telemedicine-based principal illness navigation services to these complex populations following their discharge after stroke. So this was an all-comers paper. We looked at everybody enrolled in the program for a period of time and looked at things like, can they actually enroll? Do they stay with the program? How much time is PIN utilized? Because this is a novel service to be providing to stroke patients. So there were two core questions. The first one was to help us understand enrollment rates, timing and utilization across demographics. And among those demographics, we also looked at different types of stroke and different social determinants of health needs. And the conclusion on that was that this navigator-facilitated, app-supported, telemedicine-based principal illness navigation is feasible to deliver following acute stroke discharge. We encountered a lot of early skepticism about whether patients could use this and would engage with it. And we found across age, race, ethnicity, functional status, and social need, there was very high engagement with this service. We also wanted to explore 90-day readmission rates among patients receiving PIN. And what we found was that these readmission rates compare really favorably to published literature. And the causes of readmissions were diverse, and they were not atypical for the patient population that we've seen in previous publications. Now, to the extent that we had positive readmissions, we do need to interrogate further how much is patient selection versus the program actually having an impact on readmissions, and we'll continue to explore that. So let's look at all the different cohorts that we looked at in this population. These are the tables from the paper, and I'd encourage everybody to go directly to the paper to explore it in detail. But we defined demographics across the genders, ages, races, ethnicities of the patients enrolling the population. And then we also looked at, did they have a care partner enroll with them? What was their primary insurance status? And how many social determinants of health needs did these patients have? We also looked at details of their stroke. So where did we receive the referral from? We took referrals from acute care hospitals, inpatient rehab facilities, outpatient visits in community settings. What impairments were they dealing with? And specifically in the paper, we look at whether they had aphasia or hemiparesis. What was their modified Rankin score at enrollment, dichotomizing that between dependent and independent populations? Was their stroke ischemic, hemorrhagic, or something else or unknown? And you do see in a lot of these community referrals, they don't actually know their stroke type. And then what was their discharge disposition? So we looked separately at patients going to home or inpatient rehab. Importantly, in these tables, we're looking at how much time did patients need of principal illness navigation, and what should we expect in terms of the PIN program. And you see that it is really consistent across all of these diverse cohorts. So it doesn't change very much based on demographics or stroke details. There was one area we saw that was highly correlated, and that is the number of social determinants of health needs. And I think this is interesting at both extremes. So you see that for patients who had no SDOH needs, they still required over 12 weeks over 4 hours of care from a navigator. So even if you don't have issues with transportation, housing, etc., you still need help navigating a stroke because stroke is hard and complicated. But as you look at populations with more social determinants of health needs, and particularly in this population with 5 or more needs, that population needed over 50% more time from their navigator. So this population averaged over 6 hours of one-on-one time with their navigator. And that speaks to how much harder it becomes to manage stroke when you do have these needs. And so the takeaway from this is really, if you're designing a principal illness navigation program, you need to be able to address this holistic set of issues. You need to address both demographics, social determinants of health needs, as well as the complexities of the stroke itself. Now, looking at the readmissions outcomes across cohorts, it's the same groupings as before, so I won't re-review what the groupings are, but what you see is that none of these sections are highlighted because actually the readmission rates were really consistent across demographics and types of stroke in this population. And that in itself, sort of the lack of the readmissions clustering in one population, is exciting because when we look at broader data sets, when we look at Medicare data, you tend to see higher readmission rates in a lot of subsets. Certain races, ethnicities, ages, and economic status of patient are correlated with higher readmissions. And so the fact that we're not seeing that in this population may provide an early signal that we're actually mitigating some of these things that are associated with readmission and helping patients manage them. Overall, what you see in this data by cohort is that the readmissions were around 9%, 10%, and that compares really favorably at 90 days with the literature, where we see more like 26% in readmissions. Again, this is a statistic that's going to need more exploration. Talking a little bit about those SDOH needs and what we saw in this population, nearly 3 out of 4 patients had at least one SDOH needs, and nearly 1 in 4 patients had 5 or more. So it was the normal experience in this population that they were struggling with their social determinants of health. On average, a CANDO navigator connected a patient with 2.8 resources. And we already talked about patients with 5 or more SDOH needs needed 50% more navigator time. When we assessed the SDOH needs of this population, the number one need that patients identified was actually mental health, followed by transportation. That does actually vary a little bit with age. We see more mental health needs in our younger populations and more transportation needs in our older populations. So with that, I'm going to transfer to Karen Seagraves, and Karen's going to talk a little bit about her perspectives and where they come from and some of the ways that PIN can translate to outcomes.
Well, hey everyone, I'm so excited to be here with you today. My name is Karen Seagraves, and I'm going to speak to you today a little bit about the perspective of an administrator and how does PIN translate to outcomes and how can that help with your bottom line. Many of us as administrators are accustomed to working with our hospital goals. Sometimes they are formulated into pillars or wheels, but inevitably they have the same categories. We look at things like finance and patient satisfaction. We look at quality, we look at throughput, innovation, and particularly these days, retention. So how does PIN aim to achieve these organizational goals? Hospitals face financial penalties and consequences when patients are readmitted, and not just readmitted for an inpatient stay, but when they utilize the emergency department for care. And very often we see our stroke patient population frequenting the emergency department. Negative experiences readmissions can actually harm a hospital's reputation and impact patient retention. From a quality perspective, ensuring that patients receive the best possible care and clinical outcomes without complications is one of the primary goals of an administrator. Throughput has become more of a point of contention for hospitals since the pandemic. And what we find is that very often we're pushing patients through the system to make room for the next patient. And that shortens the amount of time we have per patient to provide education, to work on discharge planning, and to really be able to provide the kind of care that we know we should, and to prevent those readmissions. Data and performance metrics really drive our decisions and what opportunities that we have for improvement, and focusing on what we can do to help to impact that bottom line when it comes to everything from patients returning for care, hospital-acquired infections, patients who are not receiving the information that they are required to receive for something like certification, all result in opportunities for improvement. From a retention standpoint, as an administrator, we recognized very early on in the pandemic that not only were we understaffed, but we were losing the clinicians that we did have because of burnout and because of the inability to be flexible and find ways to keep those clinicians at the bedside and prevent staff turnover. So improving that clinician satisfaction and allowing to do them what they train to do and keeping them involved in that direct and frontline patient care is also a goal of administration. So what does PIN aim to achieve? Our survivors have so many limitations and barriers to recovery. Having access to the tools and resources they need can be a challenge. Cognitively, with memory and problem-solving issues, it's really hard to follow the post-discharge instructions if they did get them. Communication impairment can lead to frustration, loneliness, because patients cannot express themselves well, or they cannot express themselves to their families in terms of the needs that they may have. Psychosocial symptoms like depression and fatigue, stress and anxiety really can impact quality of life and often don't set in until days or weeks after discharge from the acute setting. And adjusting to the loss of independence, dependency on others for their activities of daily living can cause not just frustration, but guilt. And it might change patterns of behavior so that the type of needs that a patient would have that would prevent them from having complications that lead them to readmissions are not communicated to their loved ones. Navigating the complexity of healthcare systems, scheduling, insurance, billing, medications can be very challenging for someone who is not experiencing the changes that we often see after stroke. From a focus, from a fatigue perspective, from the ability to concentrate, and even just understanding who to call for what issue can be a challenge. And social determinants of health, including the ability to get to your appointments, to pay for your medications, or even to understand how to use the information that has been provided and the services that are available to you, can be a challenge. Clinicians also face challenges when providing optimal care at discharge to patients. There's a lack of alignment when you have multiple providers that are caring for a patient during the acute stay. They might see a provider who did a procedure for them. They might see the neurologist who was part of the stroke team caring for them. They might have seen physiatry. Perhaps they needed a cardiology consult. And in all of that, there requires coordination to understand, when do we resume medications? When does the patient need to follow up and with whom? And there really is a challenge in extracting that from the medical record in the very quick and often very limited time-constrained discharge for our patients from the acute setting. There are limited resources. You might have one case manager or social worker for multiple units in the hospital, and to be able to pull everything together, coordinate the family, make sure that the education is provided is very challenging. And there are unmet psychosocial needs and psychosocial assessments that would help to determine what care we need to continue to provide in the outpatient setting. And that is often not available. And this can result in a number of challenges with missed or delayed follow-up appointments, not understanding the appropriate regimen for taking medication, not understanding or even having the information available to say, who should you call in each different situation, depending on the symptoms that you might have, or the financial challenge, or understanding which physician is even managing parts of your care. Is it a primary care physician? Are you seeing the neurologist? Are you seeing the neurosurgeon? Are you supposed to follow up with the cardiologist? When do you come back for repeat imaging? When do you need lab work? So it is very challenging. And for the clinicians, this can be a source of frustration and dissatisfaction with their work, because they know they've done everything on the front end and provided incredible acute inpatient care. We might have been able to provide timely care with a thrombolytic or with a procedure to help reverse some of the symptoms of stroke, but then we send them out into the community and we recognize that they may not have the resources that they need to have a successful transition home. So what does success with principal illness navigation look like for the hospital? First of all, reducing the avoidable hospital utilization, whether it's emergency department visits whether it's being readmitted or even going to a different hospital for care. The clinician satisfaction, the reduced burnout, and being able to keep your clinicians at the bedside so that they can provide that frontline care that they need, and then allowing the access for the patients to have timely, quality care in the ambulatory setting, having access to timely, quality data at 90 days. We are really looking not just at the modified Rankin scale score at 90 days, which many organizations collect for regulatory purposes, but also really understanding, are our patients coming back? Are they coming to their follow-up appointments? Did they get connected with a primary care provider? Are they coming back for their ambulatory visits as scheduled? Are they successfully completing the plan of care as designed by their care team? Keeping the hospital clinicians at the bedside allows for improved education and discharge planning instead of someone being holed up in an office making phone calls trying to get in touch with patients to determine how they're doing when they leave the hospital. So therefore, patient and family satisfaction is improved. We understand that many times after they leave the facility, there are questions and there's confusion as to who do I call? When do I come back? We get phone calls in the hospital sometimes that they're just calling the inpatient unit where they were admitted, or trying to call any physician that might have provided care for them while they were in their hospital stay. And as you know, most of those providers are hospitalists or intensivists who don't see patients in the ambulatory setting. So really being able to provide that connection so that our families feel well cared for, so that our families aren't falling through the cracks, and they have that ongoing healthcare resource so that they really have the opportunity to have a better outcome. And this keeps them coming back. I feel as an administrator that providing this wraparound service for a family and for patients really allows for them to continue to trust us with their care, and making sure that not only are they coming back, but that for all of the services, all of the testing, all of the future appointments that they may need, they will come back to our hospital system, and we will keep them for the duration of their illness and hopefully their wellness.
It's always so important when you're talking about life after hospital discharge to hear it directly from stroke survivors. And so we are really blessed by the number of survivors who are willing to share their stories and actually excited to share their stories so other people can hear them. So we're going to now share one of our survivors with their perspectives on what it was like going home after stroke and how principal illness navigation really changed that trajectory for them.
My view on recovery before ever linking up with Candu, it was very intimidating. Again, I didn't know what to expect afterwards. I didn't know how long the healing process was. I don't know how long it would take to get my mobility back. Not to mention, I didn't know that it was going to take such a toll on my psyche and my mind and how I perceive things and feelings and emotions. Once I got connected with my navigator in Candu, I became okay with recovery in the way that, like, I knew what to expect. You know, it's kind of like take me by the hand and guide me, please, because I don't know what just happened to my brain. I was more scared about being able to find a doctor that was going to help me afterwards. That was just the biggest fear. It's like, I need help, but I don't know where to begin. So it was like getting the right doctor and whatnot and making sure that they were giving me the information needed. The biggest worries were, am I gonna have enough for medication? Am I gonna have enough for therapy? Am I gonna need any medical equipment? Am I gonna have to rearrange stuff around the house? Being able to get resources, even as something as simple as just getting food, was very, very helpful. Because it was one thing I didn't have to worry about, which let me focus on what was important, which was my recovery. Now that it's been a year, my recovery keeps going forward. It keeps progressing. Thanks to Can-Do, thanks to the care of my navigator. It's joyful. It's a sense of fulfillment and accomplishment. I don't know what recovery would have looked like without this help. I don't want to imagine it.
So in conclusion, Principal Illness Navigation feels like an incredible resource to help improve the trajectory of stroke recovery. It facilitates a successful transition home, but also into recovery beyond just going home for a broad population of stroke patients. So keys to making this successful are making something simple and easy to integrate into hospitals. The hospital service line is working so hard to deliver on all that incredible complexity of acute stroke care where every second matters and things are constantly changing. And so I feel like hospital systems are so burdened already with expectations. Anything new that you're bringing and asking them to do, again, needs to be simple and easy. Whatever is brought needs to have a viable way to lower healthcare costs while improving patient care. We've talked a long time about triple aims and even quadruple aims now in healthcare, but bringing value where you're both improving outcomes and reducing cost is always a goal. We would like, as we bring outpatient services to stroke survivors, to free up clinician time, get people back to bedside, and allow them to do that incredibly important acute care work when they're in the hospital. And then finally, for patients and survivors, have a centralized place where they can get that holistic support, tools, resources, services, and needs, or resources and services to meet their needs with a consistent navigator, continually meeting with them and evolving with them during their recovery. So we're really excited about Principal Illness Navigation and looking forward to hearing more from others as they bring this new service to patients who need it.